Welcome to Ask Dr. Mingle, the Q&A series from Mingle Health, where we take your questions about quality programs and the transition to value-based care. My name is Hadley Taylor, a MIPS quality program consultant. I'll be hosting this episode along with Dr. Dan Mingle, founder and CEO of Mingle Health. Good morning, Dr. Mingle.
Good morning, Hadley, and good day to all of you tuning in. It's great to see you again. I am Dr. Dan Mingle. I'm here to answer your questions to the best of my ability.
Before we start, I want to invite our listeners to send in questions. You can leave the questions in a comment on LinkedIn or YouTube, or you can email them directly to us at hello@minglehealth.com. Okay, our first question today is from Irene. Irene asks, Dr. Mingle has mentioned that digital reporting was not discussed in the 2023 final rule. Are you referring to ECQM or CQM being required in performance year 2025 to replace web interface? Could you please explain this a little more?
Well, thanks, Irene, for the great question. The answer is no. I was not referring to the replacement of the web interface with ECQMs and MIPS CQMs. And you're not alone in confusing the terms. The relationship between ECQMs, MIPS CQMs, and the APM performance pathway and digital quality measures has been widely misunderstood. Even Medicare is distributing confusing and conflicting messaging about the subject. In 2021 rulemaking for the 2022 performance year, Medicare introduced the concept of digital quality measures, that is DQMs, proposed the audacious goal that quality reporting for the quality payment program would be entirely digital by 2025, and issued a request for input. It seemed obvious to me at the time that digital quality measures were inadequately defined, unlikely to be desirable, and unachievable to any reasonable specification in such a short time frame. My reason for bringing it up was to point out that there's no good evidence that this is going to change our lives by 2025. Two things have happened since Medicare introduced the topic in 2021 that support that conclusion. In March of 22, Medicare issued a digital quality measured strategic roadmap. You can access that strategic roadmap and other collateral on the ECQI Resources Center at healthit.gov. It's a good document. It describes the current situation well. It presents a laudable vision for a more functional future, and it lays out a reasonable and rational set of work that could credibly get us there. But nowhere in the strategic roadmap is there a mention of a date for full conversion to a digital measurement system. So it doesn't look like entirely digital system is just a couple short years away. Finally, in this final rule for the 2023 performance year, there are only two mentions of the digital quality measurement strategy and no mention of an implementation date. One mention is the acknowledgement that it was previously subject of a request for information. The other mention is in a routine footnote in each published measure specification. Now, I've seen evidence that ACOs are building IT strategy around the expectations that ECQMs will shortly be the only way to meet Medicare APP quality reporting requirements. Even the NACO's Digital Quality Measurement Task Force recommends against using MIPS CQMs, arguing that such a system will have to be completely rebuilt when Medicare requires ECQMs only. This involves mistaken assumptions that I think lead to strategies that are self-destructive, easily broken, and excessively expensive. It's not a good assumption that Medicare will be successful in creating a fully digital measurement system within any short period of time. It's not required by legislation. It's not even reflected in the rules except as an RFI. It is not a good assumption that your MIPS CQM vendor won't still be the best source of your ECQM measure analytics and submission. EHRs are simply not good at quality analytics and reporting, and certainly not against multiple EHRs in the typical ACO. It does not fit their business model. It's an enormous ask to expect them to report out of multiple platforms or show the necessary flexibility in measure choices and data sources. In contrast, it's a small step for qualified registries to restrict their analytics and reporting to just digital data sources. and it is a comparatively small step to acquire ECQM certification instead of or in addition to annual CMS qualification as a registry. Thanks, Irene, for the great question. I hope this explains my rationale for bringing it up.
Excellent explanation, Dr. Mingle. Thank you. Our next question today is from Wally. Wally's asking, could you speak to the recent study published in the Journal of the American Medical Association that states, study calls Medicare pay for performance program results into question. MIPS doesn't consistently correlate with process outcome measure performance in primary care.
Thanks, Wally, for the great question. I've had a chance to review the article and I find it compelling. It makes sense, it's believable. This article with lead author Amelia Bond, PhD, of the Department of Population Health Sciences at Weill Cornell Medical College, reports on a study of over 80,000 primary care providers. In the study, the group found that MIPS scores were not consistently correlated by the research group's independent assay of the quality of care. Scores were reported to have a correlation with the proportion of medically complex and socially vulnerable patients in the practice, with higher proportions correlated with lower quality scores. Considering the process and its limitations, it makes sense. MIPS places a simple set of measurements into a complex system. It makes sense to me that it more effectively measures our ability to generate metrics than it does our true quality of care. I don't think that this realization should prompt us to dump the system. Rather, it should illustrate the need to engage, perform studies of this type, and continually provide feedback to the custodians of the program. J.E. Deming and others warns us against incentive systems, that they are prone to perverse rewards, undesirable outcomes. To me, that doesn't mean that we should end the program. There's not service, there's not even life without incentives and disincentives. It's hard to have any process going without experiencing both sides of that spectrum. We have to continually monitor and adjust the incentive system to give us what we want. This article contributes to awareness that the MIPS system as a whole functions as an incentive and disincentive. We imagine that it measures a high value outcome of our healthcare system. But if this study is providing us useful data, it is to see that the MIPS system is more of a process measure than an outcome measure. Today, it shows how effective we are in the process of documenting our care and recovering information and reporting that information to stakeholders. It's not as much about the outcomes of high quality care. MIPS currently requires each participant to choose 6 measures out of a menu of nearly 200 measures to reflect the quality of our care. My friend Brian Alper, who founded Dynamed, tells me that he and his team of reviewers distilled over 30,000 evidence-based rules from the medical literature. A more true measure of quality is efficiency and effectiveness at which we deliver all 30,000 of those interventions to those to whom it is indicated. And maximal delivery of each intervention is never an accurate goal of quality. Efficiency and effectiveness has to take into account patient limitations, patient beliefs, and patient priorities. If we wish to build a high-value healthcare system, we need to systematize that care. And a technological foundation to our healthcare system needs to be steadily improved and needs to be put to work on making high-quality, affordable care accessible to all. I think MIPS, indeed the entire quality payment program, is all about pushing us in the right direction. It's about incentivizing us to systematize our care. The QPP has to evolve. At the point where it stops changing, it stops supporting high-value care. We need studies like this one to illuminate the failures and stimulate the next evolution. So thanks, Wally, for the great question and the thoughtfulness behind it.
And that was a very thoughtful answer, Dr. Mingle. It helped me understand what that study was looking at as well. Thank you. Our third question comes from Brad. Brad wants to know, are there any perspectives on what the positive adjustment is projected to be for reporting year 2022 paid out in 2024?
Brad, thanks for the great question. Submissions for 2022 are due by the end of March 2023. Then Medicare will process these submissions and determine determine scores and adjustments. There may be some indication released in the proposed rule in July of 2023. Results will likely be published in August, though will still be subject to focused review. The 2022 performance year is the last year of the exceptional performance bonus, which seems to be good for a nearly 2% positive adjustment. At the moment, COVID hardship exceptions applications are encouraged, but are not yet considered to be automatic for the 2022 performance year. That dynamic will tend to reduce the maximum positive adjustment. It does that because there will be fewer losers who will be required to put money in as a negative adjustment. My guess is that the final outcome will be in the 2 to 2.5% percentage range as maximum positive adjustment.
Our final question today is from Crystal. Crystal wants to know, is my understanding correct? The Medicare Shared Savings Program, MSSP, can still have practices that are not on a 2015 CEHRT, but MIPS participants must have a 2015 CEHRT?
Great question, Crystal. It does seem unfair and inconsistent, but there is a logic and balance to it. In MIPS, it's not a solid and unbendable requirement to have 2015 CEHRT. Any practice can choose not to implement EHR or can choose to use a platform that is not certified. The price of that choice for those practices is a 0 score on MIPS promoting interoperability. Detrimental? Sure, but it could be a sound business decision. In addition, roughly 1/3 of our healthcare providers are in small practices. Those practices get an automatic forgiveness of the promoting interoperability category score. In the complex system that is each of our community healthcare systems, most have members without 2015 certified EHRs. Now, this is reflected in the lenience that is in MSSP rules. MSSP requires that 75% of each program's participants have certified EHR. Failure can result in expulsion from the program and or unavailability of shared savings. Now, MSSP can be either an advanced APM or a MIPS APM, depending on the details of the contract, specifically the degree of risk. For the MSSP that is an advanced APM, the 75% threshold is the only compliance demanded for use of CEHRT. For the MSP that's a MIPS APM, they both have to live up to the 75% contractual requirement and are also subject individually to the promoting interoperability category scoring. So I hope this explains that the parent difference. Thanks, Crystal, for the great question.
Excellent. Thank you, Dr. Mingle. Those were definitely challenging questions this week, and you really helped us all understand more. Irene, Wally, Brad, and Crystal, thank you for the great questions. If you have a question for Dr. Mingle, please leave it in the comments section on LinkedIn or YouTube. Dr. Mingle, you know we're grateful for your insights with us today. Thank you.
Thank you, Hadley, and thanks to all of you who submitted questions. I want to be helpful, and I want this to be useful to you. Don't hesitate to correct or supplement my answers. Share your experience, ask your questions. We can be smarter together.